Okay, so this is one of our last topics. It is genetics. This is not an exhaustive discussion of genetics. You could take whole courses in it. I have a much longer video that's about 40 minutes. We are just going to cover what the OB general listeners needs to know. So in most cases, people have a 46XX or XY pattern and things go swimmingly. However, sometimes things in that process go wrong. We have basically two types of genetic disorders. We have inherited disorders and then we have mistakes. So inherited disorders run in the family. Some types of these are autosomal recessive, autosomal dominant, and X-linked. There are other types. There are translocations or other things that can be inherited. They are passed from one generation to the next. Um, Examples: sickle cell anemia, Huntington's disease, Tay-Sachs, cystic fibrosis, hemophilia, some types of hemophilia. Those are all inherited disorders. Then we have things like trisomies, which is an extra copy of a chromosome. We have monosomies, which is, when one half of that copy is not, one half of that pair is not present. And then we have de novo mutations, um, deletions, translocations, little things, changes to the gene where somewhere in that copying process, there's a mistake that gets made in the copying of genes or the division of genes or chromosomes. Genetic counseling is sort of where we want to be for our content. What genetic counseling is: genetic counselors are specialists in assessing the risk for genetic disorders, educating patients, and offering options. Um, so, somebody comes in for genetic counseling. Um, you get a very thorough history. You look at things like age, you look at things like occupational exposures that may mutate genes. You educate patients about that risk, and then you give them options. For example, if somebody has an inherited disorder and they know that they carry the gene for Huntington's disease and they do not want their child to have Huntington's disease, they can be offered pre-implantation genetic diagnosis. Somebody is pregnant and they are 37 years old. Their risk for having a baby with a trisomy is higher than their risk from having the procedure of losing the pregnancy. And so they may be offered things like amniocentesis. So those are the options we should offer. Now we come to who should be referred for genetic counseling. And this is where your testable material comes from. Advanced age is considered moms over 35 and dads over 45. At this point, mom has had all of her eggs since she was a fetus herself. So the eggs get older. The quality of the eggs is generally not as good as it was when she was younger. And other factors can lead to mistakes before that ovum is released. And so we would counsel that mom about her risk, tell her what the odds are of Down syndrome, the odds of miscarriage, the odds of trisomy trisomy 18 or 13. Dads over 45. Family history of genetic disorders. If something, when you're in the OB's office and you tell them that, yeah, I have a history, I have a family history of sickle cell anemia, they're going to refer you for genetic counseling, or family history of birth defects, and even autism now. Some autism has been linked to Fragile X, so those people would be referred. People with a history of stillbirth, miscarriages, repeated, recurrent miscarriages, more than three or more, can be referred because sometimes that's due to a problem in the genetic code that it's incompatible with life for that embryo or fetus. Infertility. Some people with cystic fibrosis have what we call subclinical cases. They don't have full-blown cystic fibrosis, and yet their cervical mucus is thicker, or they can't produce semen that is of normal quality. So those folks might get referred for genetic counseling. Positive prenatal screening tests. 28-year-old woman has the quad screen, which we'll find out about more in prenatal care, that indicates that maybe her baby's at higher risk for Down syndrome. She may be referred. People of certain ethnicities. The most common example of people of Mediterranean descent, have a higher risk of thalassemia. Ashkenazi Jews there are multiple disorders that kind of go with that ethnicity. And those folks can be referred for counseling. Consanguinity, which is second cousins or closer. Please don't laugh when I say that. I actually remember a family, and they were from Guatemala, and they were second cousins, and they had both copies of a gene for a very rare genetic disorder that interfered with collagen production. And they had 2 children with us. Both of them had this very painful disease that was incompatible with life. They lived for a few weeks. And so they were referred for genetic counseling. They did come back with a successful pregnancy later. Genetic testing. So these are some options that we can offer. You can karyotype parents. You get a blood sample from mom and a blood sample from dad, and you look at their chromosomes. And if those chromosomes have any abnormality, we can assess risk that way and maybe offer them some pre-implantation diagnosis. There is non-invasive prenatal screening for pregnant women. It is a blood sample. You look for fragments. It used to be thought that maternal and fetal blood never mixed at all on any level. And now over the last 20 years, we found that there are fragments of fetal DNA in mom's circulation. It's kind of neat. They're always with you in some kind of way. And they will analyze these fragments. They really only test for a few disorders, trisomy 13, 18, and 21. And they can see the gender, although it's not as conclusive as with an amnio or CBS. Chorionic villus sampling. This is a more invasive screening. It's done at about 10 to 12 weeks gestation. There are case reports of it being done as early as 8, but it is an early procedure. What they do is they go in and take a little sample, very tiny sample of chorionic villi, which is on the baby's side, the little finger-like projections. It's a little piece of the placenta, tiny, 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 at about 10 to 12 weeks gestation. And they analyze that. They do a chromosome analysis, and they can see a number of disorders from that. Miscarriage risk is about 1%. It is lower when you go to a center that does many of these procedures. The more experienced the provider is in obtaining chorionic villus sampling, the lower the risk to the mom. Jefferson currently has one of the better genetic testing centers in the country. So that's something to keep in mind. Amniocentesis is a similar procedure, but this uses a long 20-gauge needle through the abdomen. It's guided by ultrasound at about 15 to 20 weeks. They sample some amniotic fluid and look for fetal DNA in that, and they test the chromosomes. The risk of loss is a little less than 1%, about depends on which source you read, but 0.5 to 0.86. I've seen in centers, again, where they do more of these procedures, the risk is lower. But for either of these procedures, the patient should be instructed not to drive herself home and to report any bleeding or cramping to the provider right away. There is a small risk of post-amnio rupture of membranes. Sometimes the woman should be instructed to report any leaking of fluid from the vagina. And then they can do chromosome studies on a newborn if they suspected a diagnosis and mom did not want invasive testing during the pregnancy. That's usually gotten with a heel stick. Or they can take a tissue sample from a stillborn fetus. And that is genetic testing. Things that we can offer to people in terms of helping them with genetics, if, say, dad carries a gene that would be harmful, you can use a sperm donor, or you can use what's called pre-implantation genetic diagnosis, and that involves IVF. They test the IVF embryos for implantation, and they only select the ones that are healthy. And that's, a couple of the options. You can use sperm donors, egg donors. But there are some options that we can provide people. Most of it is a risk assessment and counseling. So that is the end of that.